because the test has to be some special dark field kind that's not commonly done in labs. So usually you're going to get a blood test. And that blood test is a serology test, and it's not just one. You do the test and you have your answer. It's three. 3 separate tests. Sometimes 2.
Is it done at the same time, or is it 3 separate times?
Usually it's done at the same time. You do one test and you get a reflex to the other test. So hopefully you can do that for one sample. I'm not going to get too in-depth in the tests themselves. Again, I can talk about that forever. But there's different tests. One basically detects antibodies. And if that's positive, you move on to the next one, which detects antibodies too, but it's a tighter result. So one of them will actually get you like a quantitative value that becomes important later on. Because once you have syphilis, you will always test positive for syphilis. And so there's a different test you do if you want to know if there's reinfection. It can get complicated, I'm not going to get too far into it, but just know once you're positive, you'll always screen positive. So sometimes it freaks people out. Oh my God, I thought it cleared. Why is it positive? Well, we got to do additional testing. Treatment depends on the stage, which is very important. Why it's hard to actually stage where someone's at, especially if they don't remember any symptoms. So there's certain criteria we use to stage people, and then give them the treatment based on that. The treatment is bicillin, called BIC. Not commonly in primary care offices. You'll find it in the hospital, but not primary care. But the health department will actually deliver it to them.
Is the damage permanent when, like with the neurosyphilis and the ocular syphilis, if once the damage is done, it's done?
Some of it, yes. And actually, it can cause almost like a dementia in some people. So I know there's been studies that say that a long time ago, a lot of the insane asylums might have been actual syphilis patients because the symptoms look kind of similar.
But you're contagious even if you're in latent?
Not in latent. Only when you have that chancre or some of those secondary symptoms like the rash or the wart-like lesions.
Okay, and so...
After that, we don't consider you infectious.
Interesting.
Yeah. Syphilis. This is mainly in men who have sex with men. Over 52% are men who have sex with men. Another 6% are men who have sex with men and women. Still men who have sex with men. Another 14% are men who have sex with women only. 17% men who are liars. No. Men without data on sex of sex partners. And only 11% are women. 89% are men. So when you're doing screenings, if you have a young male, many partners, he has sex with other men, test for syphilis. HIV. HIV is a virus, and with the other viruses we talked about, herpes, obviously you don't treat viruses with antibiotics. And generally they're not cured. Same with HIV. You can't cure HIV. You can take a medication to suppress HIV, which we'll get in. I like to use the capsule analogy. I'm sure you've had some classes already on HIV. But basically your body's a capsule, and your immune cells are the soldiers. HIV gets rid of those soldiers, so your body is susceptible to incoming attacks. People ask, well, what symptoms does HIV cause? HIV doesn't really cause any symptoms. It's not HIV that causes symptoms. It's what's coming in after it wipes away your defenses. Now, when you first get HIV, you may actually have some acute reaction, like a fever, kind of malaise. If that's any time during the winter, you would absolutely not know any different than anything else. So typically, people aren't going to notice that acute fever-like reaction, and most people actually don't even have it. So the symptoms that you might see later on, years later, are due to other opportunistic infections that have entered your body. So not HIV, but what it has allowed to enter in. AIDS is not infectious. AIDS is a later stage of HIV. So AIDS and HIV are not separate. AIDS is not its own thing. AIDS is just a later stage of HIV. AIDS, now when you look at your soldiers, those are your immune cells, your T lymphocytes, and we call it CD4 cells. When your CD4 count goes below 200, you are defined as having AIDS if you have HIV. So it's not like a huge jump sometimes. You know, you have 201, 190, then all of a sudden you have AIDS. So it's not like it looks a lot different in most people. It's really just looking at the CD4 count. And if you have an infection, there's a certain list of infections that if you have it, a normal person wouldn't have got that infection. So you know your immune system is so low that you've gotten these infections that normal people would not. Those are also AIDS defining. So we kind of use some of those to say, hey, you've progressed into AIDS. Still HIV though.
So if a person suspects that they might have sex with someone with HIV, they go in and get tested, right? Or is there an incubation period or what?
Both. There is an incubation period. And I'll talk about that right now. So, real brief, so I can go to the next part. Testing, you can get a rapid test, you can get a blood test. If you get a rapid test, of course it has to be confirmed, that's not it. In your sick, you can do an oral rapid test, an oral swab, but they're not recommended anymore. They're not as good as the finger sticks. Blood tests and viral load. So we'll talk about viral load tests. So for treatment, of course it can't be cured, but you can take antiretroviral therapy, ART, if you have HIV. So on the bottom, treatment as prevention task. If you have HIV and you take the medication, you can suppress the HIV and your viral load can become non-detectable. When your viral load is not detectable and you have HIV and you're on medication and taking it as you should, we don't consider you infectious. If your viral load remains undetectable, even if you have HIV, if you're on medication, we don't consider you infectious. And that's called treatment as prevention. So basically you're preventing spread because they're being treated. There's a medication you can take. If you do not have HIV, you can take a medication called PrEP, pre-exposure prophylaxis. It's actually the same medication you take as if you were using it as treatment. So if you're high risk for getting HIV, you can take this PrEP medication daily, and it prevents you from getting HIV. That combined with someone who's treated, there's pretty much essentially zero risk of transmission. Now, if you've had sex with someone who has HIV, and you already did that, you weren't on PrEP, and they weren't on medication, and they definitely were able to transmit it, after that, you can go get post-exposure prophylaxis. So basically, something happened, you can go get medication within 72 hours of the exposure. After that, it's not recommended. And it's usually what we call a considered risk or a significant risk. When you have an exposure, whether it's a needle stick or sex, and you go get post-exposure prophylaxis within 72 hours, you should get baseline testing. And it includes all STIs, including, of course, HIV, hepatitis B, and a few of those, but you want baseline testing. So that's going to detect what your current level's at, because there is an incubation period, and it could take a few weeks to a few months before it shows up. And you want that baseline because if someone had it before, you need to know. You don't want to test them just after, months after, because you need to definitely know that it was that encounter that caused infection. So you will get tested right after an exposure, but that's considered baseline testing. And then there'll be intervals where you get tested again. That could be 3 months, 6 months, depending on what's happening.
So for a post-exposure, we're saying it's confirmed exposure, correct?
Yep. Or something you can't.
Or
You
are we
can't
doing a
do.
risk analysis to
Yeah.
say, we don't know for sure, but there's a high likelihood.
Yeah. The majority of people who get post-exposure don't need it. But you do need to do, and it may not be you as the MA, but you do need to do a risk analysis. So if you have a needle stick injury, you can't really determine where that needle came from. So I'll get into another slide. The risk is still low, but it ends up being that client, that patient, and the provider to talk about it and decide what's best for them. But you can make an argument to say, yes, let's get post-exposure off of that needle stick injury. If you know the status of the person, and you know they're HIV positive, and do not have an undetectable viral load, yeah, that's definitely a reason that you would get it. Most of the time you can't determine the source, if they're positive or not. But I've even had clients who were exposed to someone who were on medication and had an undetectable viral load and an insignificant exposure, but they still decided to go get it. Because I can't say there's zero risk. And when you can't say zero, people don't want to take the chance. So that's a decision they can make. Yeah.
I'm sorry with all the questions.
No, absolutely.
Because where I work at, we get into this stuff here.
Yeah.
So the PEP, if I understand correctly, most providers, clinics in the county don't carry that. It's at the emergency ER, right?
It's actually a prescription. So any provider can prescribe it.
Yeah, but if someone comes in on a Friday,
If they want a same day, yeah,
Yeah.
they're gonna have to go in. You do have 72 hours. Of course, on a Friday, that's not gonna work out too well for them.
Right.
But there are programs, especially with the drug companies that offer it, that will expedite shipping to you almost next day.
do you guys carry PEP?
Do not.
Okay, so like Hoagland's Pharmacy, that sort of thing?
I'm not sure if they will or not. I think it actually will just get sent from the manufacturer, yeah, from the company.
So that's like 48 hours right there.
Yeah, they will expedite it to next day for post-exposure. Yeah. Again, most people don't need it. HIV, 70% among gay and bisexual men. It's 2014 data, a little bit older, but still pretty close. 7% among people who inject drugs, but that also includes people who inject drugs and have sexual partners. 23% among heterosexuals. Now, of new HIV diagnosis, black male-to-male sexual contact, definitely the highest risk and the highest for new HIV infections. This is 2016 data, followed by Latino, MSM, white MSM, black women, black men, heterosexual, white women, Hispanic. So I originally watched a presentation where they said the lifetime risk of a black African American male who has sex with men has a 1 in 2 chance of getting HIV in his lifetime. So the odds are highly stacked against him.
And are there reasons for that? I mean, outside of just education and demographic issues, is there a genetic predisposition? Is there?
You know, I'm not positive about genetics. I think it's mainly kind of the social cultural aspects of it.
Yeah, that's what I was.
But I'm not positive. New diagnosis by age, 2016 data. Look at the 20 to 29 year range. Our highest risk is with younger people. I'm going over time. All right. So here's an interesting slide that I included because it is the per act probability of acquiring HIV from an infected source out of 10,000 exposures. You get a blood transfusion, you're probably going to get HIV. But it's definitely not common to have blood sources that are infected with HIV. They're screened. Needle stick sharing during injection drug use. 63 out of the 10,000 exposures. Let's go down to just a needle stick, 23. So if someone goes walking down the street and they get poked by a needle, oh my god, go get post-exposure prophylaxis. The risk is pretty low, but I can't say it's zero.
Right.
So like I said, most people that get post-exposure probably don't need it, but
Question, how long does HIV stay on, say a surface? It doesn't stay very long, does it?
no, HIV is not a hardy virus. Yeah, it can survive in a needle for a little while if it's contained. But otherwise, any kind of general cleaner can kill it off the surface. It's usually not a risk, much of a risk. I can't say there's zero.
Right.
So even for oral sex, it doesn't even list anything. It's just low. It's below 4 out of 10,000. And these are negligible. Biting, spitting, throwing body fluids. This is funny because we get calls all the time from the police. They got spit on and they want post-exposure prophylaxis. And they want it now. And I'm like, it's a pretty insignificant risk.
It's not only police though, we get calls from teachers who students have
yes.
done things to the
Yeah,
teachers.
I've had calls about students with disabilities that have bitten someone or spit on them, and they don't even want to go through the process of trying to test that source person because it's just not a risk, and I don't like enticing the idea that it's a huge risk. But that's a fun slide. I'm gonna skip through HPV. Now, are most of you familiar with HPV? Really, the bottom line is that there's a vaccine for it. It's not something we're concerned about symptom-wise, in a sense, because HPV, there are a lot of different types. Some are higher risk and can cause cancers.